All right, today we're diving into one of the most challenging and frankly one of the most profound topics in all of neurology, motor neuron disease, or MND. We're really going to zero in on its most common and most devastating form, which is amyotrophic lateral sclerosis, what most people know as ALS. So let's get right into it.
To really get a handle on the gravity of this, we have to start right here. This quote, it's not just some clinical observation, it captures the core human tragedy of ALS. It describes this condition where a completely lucid, aware mind is for all intents and purposes trapped. It's forced to be a passenger, just witnessing the slow, relentless dismantling of its own body. And that paradox is really the key to understanding the true impact of this disease.
So here's how we're going to break this down. We've got 6 parts. We'll start big picture, mapping out the whole landscape of motor neuron diseases. Then we'll zoom right in on the core problem in ALS. From there, we'll see how that translates to what a patient actually goes through. We'll untangle a couple of really critical brainstem syndromes, look at some other important variants, and finally, we'll have to confront the tough realities of diagnosis and prognosis.
So let's jump right in. Before we can really get into the weeds on ALS, we first have to understand the wider family of motor neuron disorders that it belongs to. You've got to know the context.
So what are we talking about at the most basic level? Well, motor neuron disease is all about the death of motor neurons. Specifically, as you see here, it targets the nerve cells in the spinal cord called the anterior horn cells. These are the final messengers, the cells that actually tell our muscles to move. And when they die, that connection is just severed. And that's the absolute hallmark of MND.
Okay, so we classify these diseases based on where the damage is happening. A good way to think about it is like a 2-part command chain. You have the upper motor neurons, or UMNs. Those are the fibers coming down from the brain. They're like the generals giving the orders. Then you have the lower motor neurons, or LMNs, which are in the spinal cord. They're the soldiers actually carrying out those orders. Now, some diseases only affect the soldiers. Some only affect the generals. But ALS, the focus of our discussion, is so devastating because it attacks both parts of the chain.
Okay, now that we understand where ALS fits in the bigger picture, let's zoom in. In this section, we're going to dissect the core degenerative process of ALS itself, the most common and the most aggressive form of MND.
Now, what's really striking is that for a whopping 90% of patients, ALS just seems to appear out of nowhere. It's what we call sporadic, no known cause. Only about 10% of cases are genetic, and these are often tied to a mutation in the SOD1 gene. This gene makes an enzyme called superoxide dismutase, which is basically a crucial antioxidant. Its job is to neutralize damaging free radicals in our cells. So the fact that it's faulty points pretty strongly to oxidative stress as a way these cells are dying. And typically, the patient we see is male, around 60 years old.
So what is actually degenerating? The entire clinical picture of ALS really stems from the breakdown of these 4 key structures that you see laid out here. We lose 2 lower motor neuron structures, those anterior horn cells in the spinal cord we talked about, and some critical nuclei in the brainstem. But at the exact same time, we're losing 2 upper motor neuron structures, the cortical spinal tract controlling the limbs and the cortical bulbar fibers controlling the head and neck. It's this double hit, this UMN and LMN combination, that truly defines the disease.
Okay, on to section 3. How does this underlying pathology, this breakdown of structures, translate into what the patient and the clinician actually see? Let's look at the clinical picture of ALS.
Now, you might think the disease begins with weakness, but it almost never does. The very first sign is typically wasting, or what we call atrophy. It usually starts distally, out in the hand and forearm muscles of just one limb, and it's asymmetric, one side, not both. Along with this visible muscle loss, patients will get these little muscle twitches, we call them fasciculations, and cramps. It's usually the wasting that brings them into the clinic.
This right here is an absolutely critical point. A lot of people, probably most people, experience benign fasciculations. A little muscle twitch in your eyelid or your calf on a perfectly healthy muscle. That is not MND. The key diagnostic feature, the thing we look for in motor neuron disease, is the presence of those fasciculations on a muscle group that is already showing visible signs of wasting and atrophy. That's the difference. And this quote, it just perfectly illustrates the single most important clinical sign of ALS. It is the great paradox of the disease. You have a limb that is clearly wasted in atrophy. That's a classic sign of a lower motor neuron problem. But then you go to test the reflexes on that same limb and they are brisk, they're exaggerated, a classic sign of an upper motor neuron problem. Finding that combination of completely opposite signs on the same limb, that is pathognomonic. That is MD.
You know, what makes this disease so profoundly tragic isn't just what it destroys, but what it leaves completely untouched. Higher mental functions, cognition, memory, all intact. The sensory system is completely spared, so patients can feel everything. The autonomic nervous system, the part that controls things like heart rate, is fine. Control of the bowel and bladder is also preserved. And even the muscles that move the eyes are spared until the very, very end.
All right, next up, in Section 4, we're going to explore two really critical syndromes that show up when the disease hits the brainstem: bulbar palsy and pseudobulbar palsy. You can think of these as the LMN and UMN versions of the disease playing out in the head and neck.
Let's just walk through this table, because the key differences are night and day. On the left, you have bulbar palsy. This is a lower motor neuron problem. So look at the signs. The tongue is weak and wasted. It's flaccid because that final nerve signal telling it to contract is just gone. For the same reason, the gag reflex is absent. Now contrast that with pseudobulbar palsy on the right. That's an upper motor neuron problem. Here, the tongue is tight and spastic because the brain's inhibitory signals are lost, letting all the reflexes just run wild. But maybe the most profound difference is right at the bottom: emotional incontinence. This is a purely UMN sign where patients have these uncontrollable, totally unprompted episodes of laughing or crying.
Now for Section 5. While ALS is definitely the main player, it's really important to know about some other distinct variants of motor neuron disease because they can sometimes be part of the differential diagnosis.
So let's take a look at Kennedy's disease. There are 5 key things to know. 1, it's X-linked, which means it mostly affects males. 2, and this is a big one, unlike ALS, it's a pure lower motor neuron disease. 3, the genetic cause is a trinucleotide repeat, kind of like in Huntington's disease. 4, it has this unique association with androgen insensitivity, which can lead to things like gynecomastia. And finally, clinically, it often shows up with a mix of both tremors and fasciculations, which helps you tell it apart. Hirayama's disease is another really important one to know about. It typically hits young men, and it starts with weakness and wasting in just a single arm. It really can mimic the start of ALS. But the key life-changing difference is that it's non-progressive. The cause is totally mechanical. When the person flexes their neck, a tight dural canal actually pinches the spinal cord, cutting off blood flow to the anterior horn cells. And since it's benign and doesn't progress, telling it apart from ALS is absolutely vital. And that brings us to our final section: diagnosis and prognosis. This brings everything back to the clinical reality for patients who are facing this disease. You know, even with all our amazing modern technology, the diagnosis of ALS is still overwhelmingly clinical. Yes, we have tests that can provide supporting evidence, like a needle EMG that shows fibrillations, or an MRI that can show this hyperintensity along the cortical spinal tracts, but none of them are definitive. The diagnosis is made by a skilled neurologist who recognizes that classic, paradoxical mix of upper and lower motor neuron signs in the same patient. And this is maybe the most sobering part of the whole discussion. Right now, there is no cure. While we have a few drugs like riluzole and edaravone that have been developed to try and slow the progression, no therapy has been able to make a truly significant change in the final outcome of the disease. And that outcome is just stark. From the moment those first symptoms appear, the average survival time for a patient with ALS is just 3 years. For some people, it's even less. It's a relentlessly and unforgivingly progressive disease.
And so, at the end of it all, we're left with this central question of ALS, a question that really goes beyond just medicine. How do we, as a society, as clinicians, confront a disease that systematically isolates a lucid mind inside a failing body? It really forces us to realize that the search isn't just for a cure for the body, but for a way to care for the consciousness that remains trapped inside.